call this meeting to order. Welcome to meeting number 28 of the House of Commons Standing Committee on Health. Today we meet for a one-hour briefing on labour shortages in the healthcare sector and the Foreign Credential Recognition Program. And in the second hour, a briefing from the Public Health Agency of Canada in relation to the study of the emergency situation facing Canadians in light of the COVID-19 pandemic. I'll forego the usual announcements on hybrid proceedings. We're all quite familiar with them at this point, as I believe are the officials who are appearing before us. I would like, if we can do it right off the top, folks, because I always tend to forget this at the end, I'd like to set a deadline for the submission of witness lists for the children's health study that we will be resuming in September. And after discussions with the clerk, I'm going to make a suggestion of July the 18th. We'll send out a reminder, or the clerk will send out a reminder a couple of weeks before the deadline. Is July 18th for witness lists on the children's health study okay? Sure. Everybody okay with that? We have consensus? Mr. Garand? Mr. Backrack? Oui? Okay. So adopted by consensus. Thank you. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. I will now welcome our witnesses who are with us for the first hour this afternoon. From the Department of Employment and Social Development, Andrew Brown, Senior Assistant Deputy Minister, Skills and Employment Branch, and Aaron Connell, Director, Skilled Newcomers, Employment Integration and Partnership, Skills and Employment Branch. So we're going to begin with a 5-minute opening statement. If one of you has an opening statement to present, welcome to the committee. You now have the floor.
Great. Thank you, Chair and committee members. I'm joining you from the traditional unceded territory of the Algonquin Anishinaabe people. I'm pleased to join you today to provide an overview of labor shortages in the healthcare sector. As you may know, labor market pressures are affecting practically all sectors of the economy and most regions of the country. As of March 2022, there were more than 1 million job vacancies across Canada, which is significantly higher than pre-pandemic levels. These vacancies will take longer to fill given the scarcity of such high qualified workers among the unemployed and the need for specialized training. Le secteur de santé,
the healthcare sector in Canada, is not immune to this. The sector was already experiencing a shortage of workers prior to the COVID-19 pandemic, and this shortage has only worsened since. Actually, in the fourth quarter of 2021, the sector had the second highest number of vacancies in the country. In other words, 126,000 vacancies. Over the medium term, job openings over the next 10 years will be significant, specifically for key professions in nursing, medicine, and also other attendants.
On helping to address the health human resource crisis through its skills and training programs. For example, Budget 2021 announced $960 million for the Sectoral Workforce Solutions Program to help key sectors of the economy implement solutions to address current and emerging workforce needs. The health sector is a key sector for investment under the SWSP. The program launched a call for proposals in January that closed in March of this year, and these proposals are currently under assessment. Projects are expected to begin as early as summer 2022, this year. Additionally, as announced in the Fall Economic Statement of 2020, ESDC is funding a $38.5 million pilot project to help address labor shortages in long-term and home care. This pilot will train up to 2,600 supportive care assistants through a micro-certificate program and paid work placement, of which 1,300 are expected to continue on to pursue full personal support worker certification. Il y a aussi le programme de...
There is also the foreign recognition credential recognition program that is a contribution program that supports people trying to join the labor market. It's a system that is aiming to recognize foreign credentials. There's a standardization of national studies of alternative systems. There's also the potential to provide loans for help in licensing, testing, support services, and others in order to help qualified newcomers to Canada qualify or at least find ways to navigate through the system, and also to provide employment support, specifically training, apprenticeships, subsidies, grants, and support in order to help qualified candidates acquire Canadian experience in their field of study and to fully utilize their talents.
Internationally educated health professionals play a critical role in the Canadian healthcare system. These foreign trained professionals account for a full 25% of Canada's healthcare and social services workforce, compared to just 10% of working adults for the wider population. However, despite our increasing need for healthcare workers and reliance upon internationally educated health professionals to fill these roles, these international professionals still face some barriers to licensure and re-entry into their professions, such as costly qualifying exams, limited access to residency training, language barriers, and navigating the foreign credential recognition process. Foreign credential recognition and licensing for regulated occupations, such as nurses, physicians, and paramedics, is a provincial territorial responsibility. And in most cases, they further delegate that authority in legislation to regulatory authorities. Within Canada, there are more than 600 regulators overseeing more than 150 regulated occupations. Néanmoins, le gouvernement de...
Nevertheless, the Government of Canada recognizes there are challenges for healthcare professionals that are trained abroad. This is why the issue of their integrating the labor market is critical to the Foreign Credential Recognition Program, specifically since the beginning of the pandemic. The program currently invests $22 million in 20 programs that are focused on labor market integration for healthcare workers that are trained abroad.
Additionally, since 2018, over $13.5 million in loans have been issued to more than 1,500 borrowers through the program's Foreign Credential Recognition loans, two-thirds of whom work in healthcare. And Budget 2022 announced an additional $115 million over 5 years, with $30 million ongoing, to expand the Foreign Credential Recognition Program. Along with existing investments in the program, the incremental funding will help up to 11,000 skilled newcomers get their credentials recognized and find work in their field. For example, these investments will support projects to standardize national exams, make it easier to access information, improve timelines, and reduce red tape in order to reduce barriers to foreign credential recognition, starting with a focus on the healthcare sector. Et en plus de ces...
Aside from these investments, labor market transfer agreements provided through Employment Social Development Canada also provide about $3.4 billion in funding to individuals and employers in order to get professional training and labor support through labor market development agreements, and this is done through the provinces and territories as well.
2 millions.
Over 1 million Canadians take advantage of these programs and support programs through these various programs.
Continue to work collaboratively with federal partners, counterparts in provincial and territorial governments, and regulatory authorities to help alleviate current and future labor market pressures in the health sector. Thank you.
Thank you very much, Mr. Brown. We're going to now go to rounds of questions, beginning with the Conservatives. Dr. Ellis, please, for 6 minutes.
Well, thank you, Mr. Chair, and thank you, Mr. Brown, for appearing here today. As you well know, this is an exceedingly important question that faces all of Canadians, with somewhere between 10 and 20% of Canadians not having access to a family physician, which, as we know, is absolutely atrocious. I just have some questions. I mean, there's a lot of numbers that you threw around there, and being a physician, I guess I'm really quite curious as to how exactly you've worked with the medical regulatory authorities to get rid of red tape and to do things like standardized national exams, etc.
Great, and thank you for the question. So certainly one of the things that we are looking to do there is to take a look at ways to really facilitate the process for internationally educated healthcare professionals. And I think, I wonder if Ms. Connell may be able to assist in terms of describing a bit how we are working with provinces and territories and their regulatory agencies.
Yes, I'd be happy to. So as mentioned, the Foreign Credential Recognition Program is a grants and contributions program, project-based funding. And we are currently funding a number of regulatory authorities in this domain, which includes the Medical Council of Canada. So an example here is updating online licensure tools for international medical graduates, and helping them put exams online as well to increase accessibility for IMGs.
I certainly have had a lot of international medical graduates reach out to me personally, and certainly as a member of Parliament, to help them understand the system and help them navigate it. I guess the fact of the matter is it's very, very difficult for them to actually meet these requirements. Specifically, there was a Ukrainian medical graduate think about this, willing to take a family medicine spot anywhere in Canada, who was able to apply to the CARMS matching system. And in the second round, there are 99 unfilled family medicine spots in Canada this year for residents in training, 99. Some reason he didn't get one. Which is absolutely shocking, because he tells me he's actually willing to go anywhere in Canada to get a residency spot. So I guess, it seems like all we're doing is talking and talking and talking. And I guess the question that remains is, let's look at what happens in Nova Scotia. You need requirements for licensure, which means you need to be accepted from the World Directorate of Medical Schools. It also means that you need to have some part of your LMCC, and you need to have documentation that you were certified with the College of Family Physicians, or that you completed a one-year rotating internship in Canada before 1993. So I guess, does this mean that all we're going to do is ask international medical graduates to, again, compete in the CARMS matching system in round two?
It is an unfortunate situation for a number of international medical graduates. We are limited, or they are limited by the CARMS system that is dictated by CARMS. It's a very, as you know, the residency system is very competitive with limited seats. I don't think we as a program have levers to increase the number of seats, but we are happy to work with partners to try to facilitate and expedite the process where possible.
guess through you, Chair, to the witnesses, the primary problem here is really, the length of time that it requires for somebody who's trained elsewhere to come to Canada, do all these exams, and then get accepted to the resident matching service. That's what Ms. Elliott is referring to, Ms. Connell is referring to, the CARM system. And I guess the fact of the matter is if we're not actually going to change the process, every step in the process, what are we spending all of the money on? I don't have an issue with spending money, even though I'm a conservative. If we're actually going to do something, the question is, though, is if we're not changing it, what are we spending the money on? I do not understand.
So I think perhaps to jump in there and to respond to the question, that the role that the federal government has here really is more of a sort of convening role with provinces and territories to be identifying exactly some of the challenges that have just been identified, and notably is exactly the time required for an individual coming to Canada who's been trained abroad to have their training and experience recognized, so that they are able to gain experience here and ultimately become recognized as a licensed professional in Canada.
But the fact of the matter is if we're not going to recognize the training and experience and credentials they bring with them, that means they're still starting so many years behind, and they still need to then access the Canadian training system, which we all know is a huge roadblock. I believe that what Canadians out there are talking about is recognizing the credentials and the experience that international medical graduates bring with them already. And to spend more money to say we're going to get people into a system that already exists, quite frankly, it doesn't make any sense to me. That's not what Canadians think you're spending their money on.
So certainly hear that comment, and I think that is one of the sorts of things that we can continue to push as we work with provinces and territories, is really noting the shortages that we're facing, particularly in the health sector, is to take a look at ways that foreign credentials can be recognized more quickly, so that when foreign trained professionals arrive in Canada, they can get to work more quickly in Canada.
Okay, thank you, Mr. Brown. Dr. Ellis, next we're going to go to Dr. Pawlowski, please.
So thank you both for being here, and this is certainly a problem we've been trying to wrestle with, in that how do we make it easier for foreign trained graduates to get licensed. Now, apparently we budgeted, I believe, $150 million to help foreign credential recognition program, and I think that was broken down to some of that money could be used to help with the costly exams. Okay, I can see that. The cost of navigating the difficult credentialing program. Okay, I can see that. And then there was some mention of more residency programs, although I think someone here then mentioned that was provincial jurisdiction. I would suggest with the federal spending power, the federal government could work with the provinces in order to help create further residency programs, could it not? Now, I know during this study, I remember asking the dean, I think, of Queen's University Medical School whether they would be willing, or it may have been the nursing school, could they take more people to train? And they said yes. Is some of the money in the $150 million going towards creating more residency programs?
Thanks for the question, and perhaps I can turn to Ms. Connell to provide a little more clarity with respect to the $115 million that was announced. Thanks.
Sorry, it's 115 rather than 150. Okay.
It is. It's 115 million over 5 years and 30 million per year after that. And that's in addition to our base funding. So with that funding, we It is a grants and contributions program. We do give funding to provinces and territories, regulatory authorities, and other organizations to support the labor market integration of skilled newcomers. We will be continuing to earmark some of these funds towards the health sector, given the crisis and the number of regulated occupations in the health sector. Specifically in terms of increasing the number of residency programs, or spots, I should say, that is within a provincial territorial jurisdiction. That said, the program, whether it's FCRP or the new Sectoral Workforce Solutions program, these programs would be willing to work in partnership with our partners to help support efforts that advance the labor market integration of internationally educated health professionals.
So do I take that as meaning that you would be willing to use some of this money to create further residency programs?
We could potentially support provinces and territories who wish to create additional spots in residency programs.
Now, as Dr. Ellis has pointed out, there were 99 unfulfilled family doctor residency programs. So perhaps the obstacle isn't so much the residency programs. The problem is with the licensure. And certainly the Medical Council of Canada sets up national licensing exams, the LMCCs. Is some of that money going to go towards helping to perhaps provide education for foreign graduates who want to study and spend some time in order to upgrade their knowledge and skills so they can pass the LMCC exams?
That could certainly be a project under consideration for the Foreign Credential Recognition Program. We already have 2 project agreements with the Medical Council of Canada, as well as other provinces, territories, regulatory authorities, and immigrant serving organizations. We already have funding agreements with 20 partners in the health space, and we are open to discussing further ideas, whether it's to pilot or test something new, or to ramp up current efforts to expedite the process, put exams online, test new bridging models for international medical graduates.
There's also the possibility, it would seem to me, of creating more opportunities for practice-ready assessments, which my understanding is a way by foreign graduates can work with a licensed doctor in Canada for 12 weeks, and then the people at the Medical Council of Canada make recommendations as to further training that's available. It would certainly seem to be an opportunity. I think when we asked some of the witnesses earlier on in the study about this, they said the number of people who went through this process, the practice-ready assessment, it was in the order of hundreds, whereas we have far more empty positions than that. Is or could some of that money be used in order to make it easier for people to undergo the practice-ready assessments?
So the Practice Ready Assessment Program is currently being offered in 7 jurisdictions. Certainly, again, we would be willing to work with provinces and territories to support their priorities.
Interested in doing this. I think in my understanding as to why it's so hard for foreign graduates to get licensed are a couple of things. Perhaps protectionism within the medical community, although I would have to say, having recently spoken to the former, present, and future presidents of the CMA, they all expressed an interest in making it easier for foreign grads. But the other thing that I've heard is a potential obstacle is provinces not wanting to issue more billing numbers, because more billing numbers equals higher healthcare costs. And so do you think the provinces are really interested in licensing more foreign grads?
So I think to jump in and respond to that question, that we'd really need the provinces to weigh in on where they are there. I mean, certainly we're seeing the pressures. We know that they're feeling the pressures as well. And I think that responding to the labor market situation and these shortages, both in a broad sense, but also specifically with respect to the healthcare sector, is something that will take intervention of the federal government and as well the intervention and collaboration of provincial and territorial governments. I think particularly with respect to the healthcare sector and given provincial territorial mandates, if you will. So
well, if you go ahead, finish your thought there, Mr. Brown, then we're going to move
just to say that
Mr. Caron.
it's one where we are continuing to work with provinces and territories, and we believe that that collaboration is part of the solution.
Okay. Thank you, Mr. Brown. Thank you, Dr. Pawlowski. Monsieur Garon, pour 6 minutes.
6 minutes, Mr. Garon. Thank you very much. I'm curious about something, Mr. Brown. I'd like to know how many projects are currently supported by the FCRP program at this point in Quebec. Thank you for the question. I do not have the figures right here. Perhaps Ms. Connell can answer that question.
I can. We do have a contribution agreement with the government of Quebec, the province of Quebec, for a loans project agreement. So as Mr. Brown mentioned in his opening remarks, we do have loans projects with 11 organizations across the country. With Quebec, we've signed a 4-year contribution agreement so they can administer their loans in the manner that they see fit.
Thank you very much. I think this gets back to the question I wanted to ask you now. We've known for a while that Quebec areas of jurisdiction, even the asymmetric nature of them with respect to labor force training, this has been recognized back in the 1990s. There's been some decentralization of public service workers. It's through the Fondation Québec. Can you tell me in what way it's particularly asymmetric vis-a-vis Quebec that recognizes Quebec's skills in this area with respect to labor training? If we're referring to agreements with the provinces and territories, there's an agreement with the province of Quebec. There actually are 2 with respect to the labor market, and one on training, one on labor force. These agreements have been in existence for a number of years. And what we heard in the 2022 budget this year was that the federal government has the intention of modernizing these agreements with the provinces and territories. So the provinces and territories may have more flexibility to design their own programs for training and labor support in their own areas. It's a pleasure to hear that perhaps other provinces will gain inspiration from Quebec by recognizing their own areas of jurisdiction. That's music to my ears. There is this idea going around of the federal spending power. It seems almost be like a sugar-coated pill of sorts. The option to use this federal spending power to force, in a way, the provinces to change their strategy on immigration, to welcome candidates from abroad in the medical profession, among nurses, etc. We know that Quebec has been asking for more control over its own immigration, that Quebec is already responsible for its own economic immigration file, and there is asymmetry there. Is that an intention at this point at the federal government level? That is to really have conditioned transfers, to impose these conditions so that Quebec would be forced to make certain types of choices when it comes to economic immigration, specifically in this field of labor. As far as I'm concerned, it is difficult for me to comment on that. We were talking about immigration and the Canada-Quebec Agreement. I work in another department, of course, Employment and Social Development, and I think there was always negotiation between governments, ongoing negotiations, so that there can be a new agreement, at this point, it is clear that the federal government intends to respect its own commitments under the current agreement. Of course, we would hope that that would include respecting areas of jurisdiction that belong strictly to Quebec. Again, it's difficult to recruit in the healthcare sector because healthcare systems, specifically for Quebec, are having funding troubles, which makes labor conditions difficult. We talked about mandatory overtime with nurses. It's gotten worse over the pandemic, and the Minister of Health had to free up $2 billion in the last budget, and this is very rare, unconditional funding, so as to get a handle on these missed out, on these surgeries that didn't happen. Do you think this poor funding system, the fact that there's a refusal to allow unconditional transfers, that it has a negative effect on the labor force, that itself is an obstacle to recruitment? Who wants to go work in a system that is underfunded, where the labor conditions are difficult? Do you think that's an issue? Thank you for the question. Of course, these things, like labor conditions or working conditions, can make recruitment more difficult. Now, with respect to healthcare, you would need Health Canada employees to really answer those questions. What I wanted to say is that it's really important to have a strategy on human resources in the healthcare sector, and that is where we can help, at least from our department's perspective. We have to think about the people who are already in Canada, who can take training in order to find work in the healthcare sector. And second, you have to think about people abroad who, that we could seek out and find a way to recognize their credentials, their foreign credentials, their experience from abroad, and to recognize in Canada, recognize these things in Canada so that they may support the needs that are here in Canada. Thank you, Mr. Brown.
Mr. Bachrach, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to the committee for allowing me to be here on behalf of my colleague, Mr. Davies, and thank you to our witnesses as well. My questions start with a pretty general question about the issue of overqualification. And I'm wondering, Mr. Brown, if you can speak to whether your department has the proportion of recent immigrants to Canada who are currently working in jobs at skill levels that are below what their credentials would allow for. Is that a statistic that's easily available?
And again, thank you for that question. So that I am not certain of the response. I wonder, again, Ms. Connell, if you may be able to help out if we've got such information.
I'm afraid I don't have that statistic handy, but we would be happy to provide it in writing.
Well, would you say that that situation of overqualification is more common among recent immigrants to Canada than it is for Canadian-born individuals with comparable educational credentials?
I think that would be a fair statement to make, and really the rationale or reason behind that being the need for people who've been trained abroad to have their credentials recognized, or in fact to pursue some retraining here to then be recognized as a professional in Canada. So it does add an additional barrier for someone who is trained abroad to someone who is trained here in Canada.
Mr. Brown, you mentioned Budget 22 provides $115 million over 5 years with $30 million ongoing to expand the Foreign Credential Recognition Program and help up to 11,000 internationally trained healthcare professionals per year get their credentials and be recognized in their field. On average, how many professionals have their foreign credentials recognized in Canada each year currently?
And thanks again for the question. So this is one, certainly, of course, it's the provincial and territorial governments and regulatory bodies that are responsible for that review and accreditation. I don't know, Ms. Connell, whether we've got figures that have been compiled from those jurisdictions and agencies.
I don't have a macro number because, as mentioned, it is a provincial and territorial responsibility, and there's 150 regulated occupations. But one figure I could offer is that through our loans projects, which has the goal of helping immigrants through the foreign credential recognition process, through our loans to date, we've helped 30% of people who've received loans acquire their credential recognition, and an additional 30% found work in their field of study.
Thank you, Ms. Connell. I guess what I'm trying to get at, it's this 11,000 number. What is it based on, if not based on sort of a comparison to how many are currently being credentialed? Like, without knowing how many are currently being credentialed, how did we set this target of 11,000 internationally trained healthcare professionals per year? I guess what I'm trying to get a sense of is that a reasonable target? Is it ambitious? How does it compare to the current pace? If we're currently credentialing 5,000 per year and we want to get to 11,000, that seems like a pretty achievable thing. If we're, and I have no idea, if we're credentialing 50, then it's much more ambitious. Do you have any sense of, even in ballpark numbers, how many foreign professionals or foreign trained professionals are being credentialed?
So again, I can't give a ballpark figure. We can certainly take that back, but it's very difficult to extract that data. Some provinces are better at reporting that than others. But to achieve our 11,000 per year target, we intend to do that through our project-based funding. So that is through systems improvements that will help skilled newcomers get their credentials recognized. It's also through our loans, the number of skilled newcomers who receive loans and support services. And then also the skilled newcomers that participate in our Canadian Work Experience projects, who participate in mentorship programs, work placements, wage subsidies. So it's a collection of our interventions at a project-based level.
Right. Okay. And can I assume that the data collection is going to get better so that you know when you hit the 11,000 target? The other question I have that's somewhat related to that, is it 11,000 new internationally credentialed professionals, or is it an 11,000 gross number, including the ones that are currently credentialed under existing programs? Because this is new money that's being brought to bear. How many new credentials are going to be recognized through this program?
So again, it's not necessarily the number of people whose credentials are recognized. That could be part of it. And we do have good reporting results on our projects. So again, it would be a mixture of those who go through the credential recognition process thanks to our projects, receive loans, and participate in Canadian Work Experience opportunities.
Thank you, Ms. Connell and Mr. Bachrach. Next, we're going to go back to Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair. Thank you to the witnesses again. I'm just going to pick up on that line of questioning. We talked about 11,000 individuals being credentialed. Do you have a breakdown of what their professions are?
Hey, Erin, are you able to, sorry, Ms. Connell, are you able to jump in there?
We don't have an exact breakdown yet. This is new money, but typically we do invest heavily in the health sector. So even before the pandemic, the program invested 25-30% of its program funding in the health sector. We anticipate to ramp that up as we have started to do when the pandemic hit. So we will continue to focus on the health sector as well as reach out to other sectors in demand sectors in Canada as well, including perhaps the skilled trades, information communication technology. But certainly in the short term, the health sector is a very big priority for us.
Well, thank you very much for that. When do you anticipate having those numbers from the health sector?
After we have a new set of project agreements set up. So I would say within the year.
Okay.
We would have targets.
But you do understand that 10% of Canadians at minimum don't have a family doctor, and we're short 60 to 70,000 nurses. Okay. That being said, that means of the 11,000 people, you said 30% of them are in the health sector. So let's be kind. Let's say it's 4,000 people. 60,000 nurses. That's a drop in the bucket. I'm just going to leave it at that. I guess the question that I have is, you talked about 20 projects that you're undertaking. I think the committee would be very interested to know two things. One is how many of them are health related, and number two, of those that are health related, would you please table those projects with the health committee within the next month?
Thank you for that. We would be happy to. All 20 of the projects we referenced are indeed in the health sector, and we would be happy to table the list of projects with their descriptions.
And we would, of course, love the metrics associated with those studies. That being said, the studies that you're undertaking, are they being driven by your office, or you're asking for proposals from the provincial governments?
We have a continuous intake for the Foreign Credential Recognition Program, so we are happy to accept a project concept or a proposal from a provincial territorial government, a regulatory authority, or an immigrant or other serving organization. The program also regularly launches calls for proposals, so we are in the planning stages for that.
So if I could be clear then, it could be from anywhere from an individual to a province, but there's really not a plan here. We're spending $115 million plus your regular funding, which I'm not sure what it is. I'd be interested to hear that, on something that we're asking somebody else to plan for, even though we already know the scope of the problem in general, and we already know the urgency thereof, but realistically there's no federal plan on how to address it.
I would say there is a federal plan. As Mr. Brown said, we work collaboratively with our partners at Health Canada and Immigration, Refugees and Citizenship Canada on our piece of the puzzle.
Could I just interrupt you, Ms. Connell? Because I feel like this could be somewhat disrespectful. I don't mean it to be, but Mr. Chair, I would suggest that a plan would be somebody having an idea and outlining it, and then filling in those parts and asking other people to be a part of that, not asking other people to come up with the idea. That's not a plan. Again, I'm not trying to be controversial, but a plan would be, I'm telling you what to do. Here's the plan. Here's what we're going to do. What you're doing is convening some meetings with either individuals or provinces.
And I understand your frustration. The fact of the matter is that foreign credential recognition and licensure and certification is a provincial and territorial responsibility. I'm
going to interrupt you again because you're telling me stuff that I already know and this committee knows intimately well. And I do apologize for sounding rude. We only have so much time. That being said, if it's a provincial jurisdiction, then why are we spending an extra $115 million and your entire budget on something that is not a plan? And you know what? Again, I'll be totally honest with you. You do not understand my frustration because I'm talking here on behalf of up to 5 million Canadians who can't see a family doctor. And you don't have a plan. At least your department does not have a plan. I am exceedingly frustrated.
Okay, Ms. Connell, we're past time. You can you can provide a response without interruption if you like.
Mr. Chair, it's fine. It's good.
Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair. Thank you to both officials for showing up today. In both your responses, Mr. Brown and Ms. Connell, you talked about collaboration, and I specifically recall when Mr. Brown was responding to my colleague, Mr. Garon, you talked about the strategy, and you said the best thing we can do, we can put a strategy together. As I'm sure you followed HESA over the last year, we've consistently been hearing about the theme of pan-Canadian framework or strategy, whether it's for health workforce planning or for licensure for physicians across the country. Now, we also talked about the role that the federal government needs to play to be able to make a difference. And we do realize these are provincial and territorial and also some of these professional organizations. But can you help us understand what lever, in your opinion, both Mr. Brown as well as Ms. Connell, what lever the federal government has to be able to play a much more effective role in addressing some of these issues? Whether it's the licensure, whether it's the length of time, whether it's the residency spaces, whether it's the making sure that the supply and the demand of physicians and the jurisdiction, what lever do we have that we could apply as a federal government?
So I do thank you for the question, and I think there's perhaps a couple of different things that we can think about. I recognize a lot of focus here on the foreign credential recognition program, and I do think that is a piece of it. I think we also need to take a look at our own programs, and for provinces and territories to be looking at their own skills and employment training to see what some of the opportunities are to address the shortages. So I do think it's a number of things. Now, I might start, let's say, if we turn to the foreign credential recognition program for a moment. In that case, I might turn to Ms. Connell to see if there's specific pieces we might point to in that area that would help in terms of a federal lever.
So we do convene conversations bilaterally and multilaterally with our provincial and territorial partners to better understand their needs and priorities and talk about partnerships moving forward. This is a G's&C's project-based program. We do reach out to regulatory authorities as well. As mentioned earlier, we are currently funding 20 projects in the health sector and continue to do more in that space. So
thank you.
To that,
I apologize for interrupting you. We heard that before, but I'm not sure whether that's a lever or not. But I know that ESTC has recently released a pan-Canadian framework for the assessment and recognition of the foreign qualification, which is more a guideline to work toward improving the integration of internationally trained workers into the labor market rather than serving as a legally binding document that provinces or other organizations got to follow up. Where's the power of this document going to come from?
All right, Ms. Connell, are you able to help out in terms of reference there to the Pan-Canadian document that was referenced?
Yes, so the Pan-Canadian Framework was published in 2009 by the Forum of Labour Market Ministers. It is a high-level document with a shared vision, guiding principles, and desired outcomes. And it has served as a piece that has guided actions both federally and at the provincial territorial level. It's been a forum to share best practices and do occupational analysis to try to see where the gaps are at pre-arrival, at bridging, at credential recognition. Some of the actions coming out of this have included setting up fairness commissioners and review offices in certain jurisdictions. Others are projects to improve pre-arrival or focus on bridging. But it
Thank you,
certainly
Ms.
is.
Connell. I only got another 15 seconds, if that.
Sorry.
Do you believe that federal government can use the health transfer fund to be able to really get provinces at the table to be able to address some of the huge gaps that we have in the delivery of our healthcare services?
Brief response, please.
I think that would be a question best suited for our Health Canada colleagues.
Thank you, Ms. Connell. Suite, Monsieur Garand.
2.5 minutes, Mr. Guérin. Thank you, Mr. Chair. You know, Mr. Chair, there, back in the day in Quebec, we were losing healthcare professionals, doctors, because they would leave. And now the federal government's helping us a lot. You know, those people can't even get passports, so they don't leave anymore. There is another problem with the federal government. It's the issue of immigration. I think it's kind of looking at things backwards. Now there's talk about getting foreign people from abroad here, and you know, the most dysfunctional department here is immigration. We can't even get temporary foreign workers into Canada, Mr. Chair, in a decent time frame. So I'm wondering if our friends here today, our guests, can tell us whether a federal department of immigration that is functional would be helpful to them in the context of this foreign credential recognition work they're doing.
Okay. Merci pour la question.
Thank you for the question. Of course, we have a Department of Immigration at the federal level. I know there are always opportunities to improve things within departments in general. And this is something that we're doing within our department. At ESDC, we work with the Department of Immigration because on the issue of temporary foreign workers, we know that that's an issue that is a shared area of work, and it's also something that we're working with our Quebec counterparts. That's one aspect. When we're looking at shortages in this healthcare sector, there's one aspect of it that's that, and the other aspect is looking at the workers who are in Canada and the importance of finding ways to train here people in Canada and in Quebec specifically to fill these positions in the healthcare sector. Quickly, Mr. Chair, when I look at the $110 million under the program, then you have $30 million per year. If I were to take Quebec's share, that's $5.8 million per year. You've just mentioned labor training in the healthcare sector. The Department of Health and Education, the costs are really tens of billions of dollars. Do you think that this kind of transfer to the province is going to be able to address a substantial labor shortage with $5.8 million per year? A brief answer, says the chair. I don't know exactly what the healthcare transfer to the province of Quebec is with respect to that specific transfer. Madam Khan, I don't know if you have any additional information on that.
Merci, Monsieur Garand.
Thank you, Mr. Garon.
Back rack, please, for 2.5 minutes, and then we're going to go to the next panel.
Thank you, Mr. Chair. A bit of a segue from my last line of questioning on data. I'm sure our witnesses will be familiar with the 2020 evaluation of the Foreign Credential Recognition Program that the federal government undertook. In that evaluation, the report states that, quote, the lack of data on labor market outcomes of internationally trained individuals is an impediment to measure the impact of the program on their employment outcomes. So in light of this finding from 2 years ago, what steps is the federal government taking to improve data collection on labor market outcomes of internationally trained individuals?
And Ms. Connell, I'll turn to you. Thanks.
Yes, thank you. We, moving forward, are strengthening our reporting requirements and our results and outcome measurement of the organizations and provinces and territories that we fund. So it's really a measure of strengthening the results and reporting regime so we can accurately capture how effective the program is.
Assume then it'll be easier to know when you hit that 11,000 target. Because the provinces and the other partners are going to be reporting to you how many internationally credentialed professionals are making it through the program?
Our project proponents will be reporting those results to us. So it'll be how many loans were dispersed, how many skilled newcomers participated in a Canadian work experience, and how many skilled newcomers were helped by projects that support better foreign credential recognition. So it's very specific to our projects and our project results.
Stated that the program's ability to create systemic changes is limited since the provinces and territories have jurisdiction over credentialing for most regulated professions. I'm wondering what steps your department is taking to improve coordination with the provinces and territories and regulatory bodies with respect to foreign credential recognition.
Thanks again for the question. So again, this is one of the areas where it is really focusing on those, I guess, different aspects of the program, looking at opportunities to streamline through consistent national requirements and exams, looking at streamlining the processes for recognition of foreign credentials, and really sharing best practices. So that's sort of the convening role that the federal government is undertaking, and it's meant to facilitate the recognition of foreign credentials.
Thank you, Mr. Brown and Mr. Bachrach. Mr. Brown and Ms. Connell, I want to thank you very much for being with us here today. We've spent a significant amount of time in recent months studying the challenges around the workforce in healthcare. And if there's one thing that we learned, it's that foreign credentialing is absolutely part of the solution. So thanks for the work that you've been doing in this area. Thanks for the information that you provided to us today and for your patience with the late start. It's becoming more of the norm in recent weeks. So with that, colleagues, we're going to suspend while we have the next panel geared up. Thanks again, Mr. Brown and Ms. Connell. The meeting is suspended. I call the meeting back to order. We will now proceed to our briefing from Public Health Agency of Canada officials under our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. We're pleased to welcome here with us from the Public Health Agency of Canada, Kathy Thompson, Executive Vice President, Cindy Evans, Vice President, Emergency Management Branch, Stephen Bent, Vice President, COVID-19 Vaccine Rollout Task Force, Kimby Barton, Acting Vice President, Health Security and Regional Operations Branch, and Dr. Guillaume Poliquin, Vice President, National Microbiology Laboratory. Thank you all for taking the time to appear today. I understand, Ms. Thompson, you're going to be delivering opening remarks on behalf of the agency, so you've got the floor for the next 5 minutes. Welcome to the committee.
Thank you very much, Mr. Chair. Thank you for inviting the Public Health Agency of Canada back to provide an update on the COVID situation in Canada. We continue to monitor COVID-19 epidemiological indicators so that we can quickly detect, understand, and communicate any emerging issues of concern. Comme l'a indiqué le Dr. Tam vendredi.
As Dr. Tam reported on Friday, COVID-19 disease activity indicators from daily case counts and lab test positivity to wastewater signals are stabilizing at the national level, with most areas continuing to decline. Severe illness trends are also declining in most jurisdictions. However, the virus is still circulating in Canada and internationally, and factors such as virus evolution and waning immunity could have an impact on COVID-19 activity moving forward. At this time, we are observing early signals of increased activity in some areas. As we have said on a number of occasions, we are not expecting our progress to be linear. Dr. Tam has said that on numerous occasions. We need to continue to prepare in case there is a resurgence in COVID-19 activity. This means we need to keep up with our personal precautions, including staying up to date with our COVID-19 vaccines and wearing a well-fitted mask. This is especially important as summer approaches and Canadians get together more and participate in larger events like fairs and festivals. The steady improvements we have been seeing in epidemiological indicators have allowed us to continue to relax and pause some of our measures.
Last week, the Government of Canada announced it is suspending the vaccine mandate for federally regulated transportation sectors and federal employees. In Canada, we now have better levels of immunity for both vaccination and infection, antiviral drugs that are more widely available, and our hospitalization rates are lower relative to when the mandates were first introduced. This means we're now better equipped to effectively manage the COVID-19 pandemic and reduce the pressure on the healthcare system. The suspension of vaccine mandates reflects an improved public health situation in Canada at this time. However, the COVID-19 virus continues to evolve and circulate in Canada and globally. COVID-19 remains a public health threat. Our best line of defense against serious illness, hospitalization, and death is staying up to date with vaccinations, including booster doses. Because vaccination rates and virus control in other countries vary significantly, our vaccination requirements remain in effect at the border. This includes an existing vaccination requirement for most foreign nationals to enter Canada, and the quarantine and testing requirements for Canadians and some travelers who have not received their primary vaccine series. These requirements will help reduce the potential impact of international travel on our healthcare system. They will also serve as added protection against any future variants of concern. The Government of Canada is transitioning to a model where testing occurs outside of airports for both random testing and testing for unvaccinated travelers. Random testing will continue to occur at land border points of entry across Canada with no changes. Tout en poursuivant la lutte contre ce virus,
While we continue the fight against this virus, we are taking every opportunity to improve. We continue to learn from both our past actions and our evolving knowledge of the virus. Although the agency was able to rapidly mobilize, adapt, and respond to the evolving COVID-19 situation, as we move forward, we look to strengthening our pandemic preparedness by building on the lessons we have learned. As we look to the future, we are optimistic. However, we also need to prepare for various scenarios. In doing so, we will use science and data to help inform our response to new and evolving situations, just as we've done from the beginning of the pandemic. Thank you. We'll be pleased to answer your questions.
Thank you very much, Ms. Thompson, and we will now begin with rounds of questioning, starting with Dr. Ellis for 6 minutes, please.
Thank you, Mr. Chair. Thank you, Mr. Chair. Thank you to the witnesses for coming, and thank you for your opening remarks, Ms. Thompson. The data you're talking about, this elusive data we've heard a lot about, can you tell us what metrics you're using?
Thank you, Mr. Chair. The metrics that we use, there's not one specific metric. It's really a number of factors that we're looking at. When I look, for example, at the situation when the vaccine mandates were first put in place, at the time there was strong scientific evidence that the vaccines were preventing infection and that they were working against transmission, against Delta and Alpha, and protecting against serious illness. There was rapid acceleration of the Delta variant. Hospitalization and ICU rates were very high, and the modeling was showing a strong resurgence at the time. When we look now, comparatively, we have high immunity, both from vaccination, but also from infection rates. We have significant availability of antivirals. I mentioned the vaccination rates. Over 82% of Canadians are fully vaccinated with a primary series. We have lower hospitalization rates, and we're effectively in a better position now to be able to manage the pandemic. And that's why the decision was made to remove the vaccine mandates for public servants, but also for the domestic transportation federally regulated sectors.
And I guess the question is, as we've asked multiple times before, we would like you to table that information with those metrics here with this committee. So since you have it at your fingertips, that'd be great within the next 2 weeks, please. That being said, we talked about vaccine effectiveness. Certainly we know that the vaccines that are developed are against the original variant. With new variants of concern and vaccine effectiveness waning over 6 months, the health minister talked briefly about 3 doses being a fully immunized Canadian. Does it make sense to continue to use these old vaccines?
Thank you, Mr. Chair. Mr. Chair, the Minister of Health, Minister Duclos, did indicate last week that that primary series is going to need to include 3 doses, but we do know from the vaccine science that vaccines continue to be very effective, particularly against fighting the severity of the virus. There is also some protection offered in terms of transmission, but we do know that unlike Delta, that it does wane over time, but the vaccines are still very effective to prevent severe illness and death. So in terms of the vaccines, we continue, and Dr. Tam, the public health officer, does continue to encourage Canadians to be up to date in terms of their vaccination. It's still the best protection that's available to Canadians.
I understand that. I guess the question is, since we know that it is really not preventing transmission, and we know that even the Prime Minister who's had 3 doses of vaccine has had COVID twice, I guess I just, and this is more of a comment than a question, it really befuddles me how you could possibly require Canadians to get a 3rd dose of that particular vaccine. That doesn't seem sensical to me. It seems nonsensical, in fact. Anyway, that being said, I think that's certainly something that bears looking at. Mr. Chair, I'd like to give notice of the following motion, if I could, sir. that the committee undertake a study into the domestic and international roles of the National Microbiology Lab in Winnipeg, that this study includes discussions into the research being done at the facility, the safety and security measures in place, and the implications of recent international media stories regarding its scientific integrity, and that the committee report its findings and recommendations to the House. Thank you, sir. I'll cede the rest of my time.
To Ms. Goodridge or to the next person on the list?
Next person on the list, sir.
Very good. Okay, thank you, Dr. Ellis. Next, Dr. Hanley, please, for 6 minutes.
Thank you, Mr. Chair, and thanks to all of the representatives from the agency for attending today. I'd like to start with Dr. Parlequin. It's good to see you again, and I'm wondering. I know you've spoken previously to this committee on updates. One of the subject areas is around genomics, and I wonder if you could update the committee on how genomics has helped us respond to the pandemic in its more recent phases, and maybe whether you can comment on modeling exercises that you are currently undertaking.
Thank you, Major. Thank you, Mr. Chair. On the question of genomics, the National Microbiology Lab continues to work very closely with provinces and territories under the guise of the Variant of Concern strategy. Under this initiative, we have seen a significant acceleration in the capacity to do genomic studies in Canada, going from a capacity of approximately 3,000 sequences per month in December of 2020 to 25 to 30,000 sequences per month currently. Canada has become the 5th largest contributor of sequences to the global database of approximately 400,000 sequences coming from Canada. What that translates to in real terms has been the ability, in essence, to monitor viral evolution in close to real time here in Canada. Through that, we have been able to look at the arrival of Delta wave. We're able to detect the arrival of Omicron within days of its arrival to Canada, and have been able to use that information in partnership with public health authorities to help with decision making. Moving forward, we continue to use this capacity to monitor for the emergence of new variants. We have seen more recently the sublineages of Omicron, BA4 and 5, for example, and we are able to track these very closely to be able to inform public health decision making. On the issue of modeling, genomics modeling and other monitoring activities work hand in hand. Through our modeling programs, we have 2 main thrusts of work. The first is on short-term forecasting, where we use real data from cases, vaccination, and are able to provide an estimate of the trajectory of the pandemic in the coming weeks. And to that, we supplement dynamic modeling, in which we are able to add new science, such as how the SARS-CoV-2, the virus that causes COVID-19, transmits, evolves. And these dynamic models give us a longer-term view of expected changes in the pandemic. Through these models, for example, we continue to look for what may come in the fall, which reinforces the need for Canadians to stay up to date with vaccination and be mindful of their health choices as we navigate the pandemic.
Thank you. And I wonder if, on that note, whether you can give us any inkling of what you are anticipating. We're always looking towards the next season, whether that's the summer season of travel and gatherings, or the fall of return to school, or the winter of back to inside. So there's always another season coming. But what are you seeing in terms of patterns for late summer into fall at this point?
Thank you, Mr. Chair. At this time, we are seeing overall in Canada stabilization in the rates of transmission, though as Ms. Thompson indicated, we are seeing some early signs of increased activity in some regions which we are following closely. It is notable that we have seen, for example, an atypical flu season with higher than expected transmission rates currently. And as a result, we are looking forward to a fall with a potential recurrence in activity driven by people moving inside, closer contacts, return of school, but also the interplay with additional viral pathogens, more traditional, making a bit of a return.
Thanks. Mr. Chair, do I still have time for one more question?
Yes, indeed. You have a full minute.
Okay. I wonder if I forgot what my question was now. I was so determined about the time. There are so many questions I wonder about, just on the note, and whoever maybe can jump in, and maybe this would be back to Ms. Evans, but around your strategies for getting to Canadians to get to their third dose. We know that we have a lag in third dose uptake, anticipating what might be coming at us in the fall.
Mr. Chairman, if I may redirect that question to Mr. Bent.
Mr. Chair, in terms of encouraging Canadians to take their third doses, we continue to work very closely with our provincial and territorial partners in the context of communication to Canadians. Dr. Tam is out frequently reminding Canadians of the importance of keeping their vaccinations up to date, including third doses of COVID-19 vaccine. Our intention is to continue to work with our provincial and territorial colleagues over the course of the summer and into the fall with joint planning and communication strategies and outreach to encourage Canadians to take their third dose. Thank you.
Thank you, Mr. Bent. Monsieur Garon, pour 6 minutes, s'il vous plaît.
Mr. Garon, 6 minutes. Thank you, Mr. Chair. From the start of the pandemic at the Bloc Québécois, we've been saying that the decision to impose vaccine mandates and restrictions in airports, the idea of removing those mandates, that had to be taken by scientists, not by politicians, because it's really highly scientific. The Department of Transport recently announced that some of the restrictions would be lifted in airports, for instance. I'm wondering what the new data is that was provided by public health experts in government so that decision would be taken. And some of the decisions that were taken, I mean, were they based on science? Was it strictly political?
Bonjour, Monsieur le Président.
Mr. Chair, what I would say to that, and as I indicated a moment ago, the data and studies were greatly considered. We've spoken to a number of scientists globally and also experts here in Canada. We are always working in close cooperation with colleagues in the provinces and territories, Indigenous peoples, and other partners to determine really the state of things, the situation as it is. And we look at the data. We have a number of methods that we use to collect data, including the wastewater assessments and border data, and as I mentioned a moment ago, the vaccine rate, vaccine uptake rate. We can also see how many people are hospitalized. If you look at the first week of May of this year, and you look at the people who were hospitalized, we know that unfortunately it's still people who were not vaccinated. Unfortunately, as I say, we continue to increase and promote the use of vaccines. At the same time, if I may, I mean, time is running out. My question is this. Last week, did the Minister of Transportation make a decision based on new information or new recommendations that were explicitly made by your department and that were then tabled to him, and the Minister of Transport said, hey, today is the day to do this? Did that kind of event happen? What I would say to that is, for the Public Health Agency of Canada, we often provide advice on the data. As I said, you asked me if the data had changed. The data has changed since the time when mandates were implemented last fall. The situation has changed. The data has changed, and it is that type of information which we generally provide. When we, of course, give counsel in a general sense, when we provide advice to the government, it's the kind of information we provide in consultation with experts. Okay, sorry, I apologize for interrupting you, but I just understand that on the basis of that data and the expertise that was presented, in fact, that decision could have been taken a week earlier, 3 weeks earlier, a month earlier. We get it, that the beginning of those restrictions. Listen, I'm just trying to understand the science behind this. We understand that the beginning of those restrictions, this is something that could have happened 3 weeks ago, 2 weeks ago, not as though public health said, today is the day that you need to do away with those restrictions at airports. It's not like that things transpired. Information is always changing. There are always new studies to understand. We are always engaging with experts. And of course, the information is constantly being updated or changed. The decision the government took is in line with what we're seeing when it comes to data and the general direction of the pandemic at this point. Could the same decision have been taken based on what you have seen, taken 3 weeks ago, a week later? As I say, data is always changing. There are studies coming out in a dynamic way. It's always changing. We provide this information. We're constantly managing these studies, consulting with experts, and providing advice. Of course, the government needs time to really appreciate that information that has been shared, provided. The appearance of new foreign variants that have sort of developed in other jurisdictions, places where there are fewer vaccines or the vaccine rate is lower. The fact that these variants have arrived in Canada or that they could cause new waves or damage, is this still a concern for public health authorities in Canada? Yes, clearly we're looking at new variants closely. We also have border measures in place for that very reason. Perhaps I could turn to Dr. Poulican so he could maybe give us more information on the new variants. Yes, thank you, Mr. Chair. We can see that the virus, SARS-CoV-2, that causes COVID, continues to evolve. It is not possible to determine exactly the direction of the short or long term of COVID. But what we have determined through our genomics and our scientific experts is that, and academic experts, I should say, is that we've developed a network to study the variants, get a good grasp as soon as possible as to their potential impacts, and we want to be able to advise public health as to the measures to be taken. Thank you, Dr. Poulican. Thank you, Mr. Garon.
Back, please, for 6 minutes.
Thank you, Mr. Chair. And I'd like to start by thanking all of our witnesses for their work over the past years in what have been some pretty extraordinary circumstances for our country. I'd like to pick up where my colleague, Mr. Garon, left off and talking about the travel mandates. This is an issue that has affected a lot of people in the riding I represent. And I know that, several of those measures have since been lifted. But at the same time, people are frustrated by the lack of explanation as to what the criteria were and how the decision-making process worked. So I'd like to start by going back to earlier in the pandemic when the vaccine became widely available and the government chose to put the vaccine mandate for domestic travel in place. So these are rules that prevent unvaccinated people from traveling on airplanes and trains within the country. Now, Ms. Thompson, could you speak to how those rules were designed to work? I mean, I'm trying to get at the heart of this. What is the mechanism or what is the specific risk that was being managed when those rules were first brought in?
Thank you, Mr. Chairman. With respect to vaccine mandates, as I mentioned, the national but also global epidemiological situation was very different than what we have today. There was modeling that showed possibility of strong resurgence. We were in between alpha and delta variants, and while we did have a high vaccination rate even back then, there were pockets and subpopulations that were not vaccinated, including younger people, younger individuals. And so at that time, the government made the decision to increase the uptake of vaccines with the vaccine mandate to offer some additional protection and ensure that particularly with respect to travel and small conveyances, to ensure that there was additional protection through the vaccine mandates at the time.
So can I take it from your response, Ms. Thompson, that the key objective of the vaccine mandate for domestic travel was to encourage Canadians to get vaccinated as opposed to preventing transmission in a travel environment?
It was certainly to encourage vaccination, but at the time we were also looking to protect Canadians from COVID, from severe illness, from hospitalization, and there was very strong evidence to show that the vaccines were very effective for all of those risks that we were facing at the time.
Take it from your response that reducing transmission in a travel environment, that is on an airplane or on a train, was not one of the original objectives of the vaccine mandate for travel?
Mr. Chair, the objective of all of the measures that are in place is really to protect Canadians and the health of Canadians, and in particular people that are vulnerable, immunocompromised. So that is the first objective in all of these measures, in addition to promoting vaccines, because we had good evidence that vaccines were very effective, particularly against Alpha and Delta, and because we knew that there were some regions of the country and some populations where we didn't have the protection that we were looking for. That was necessary.
I have to say, Ms. Thompson, I'm frustrated at the generality of your responses, because I think what Canadians are looking for is a very specific explanation of how these rules work. And that's what we've been failing to get for so many months now. It's just incredibly frustrating. I'm a layperson. I'm not an epidemiologist. I'm not a health professional of any kind. I studied glaciers in university. But I feel like I should be able to understand what we're trying to do with these rules. And the explanation is just, it's not making sense. So I'm wondering if you can try again to tell us how keeping people off of airplanes and off of trains very specifically protected them or protected people around them. Like I'm failing to see it. I thought I understood the mechanism, which was that if you're unvaccinated and you're carrying the virus, there's less chance of you transmitting it to people around you. I think that's how most Canadians understood those rules to work. And in addition, there's this piece around trying to convince people to get vaccinated. But the piece around transmission is particularly interesting because of what we've been told about how the virus evolved and the changing impact on transmission. So I'm looking for something here because I'm not clear on how these rules were supposed to work.
Thank you, Mr. Chairman. Certainly, we want to be as clear as we can with Canadians, and Dr. Tam always makes sure that during her briefings that she communicates to Canadians what the situation is in Canada, as well as do other departments that have imposed measures, whether it's Transport Canada for a domestic vaccine, for federally regulated sectors, or Treasury Board for public service. And so, Mr. Chairman, just with respect to the federally regulated sector, as I indicated, there was strong evidence from international and domestic sources to conclude that vaccines were very effective at preventing infection and consequently transmission against the COVID variants that were circulating at the time, namely Alpha and Delta, and as I said, protecting against severe illness and hospitalization and death. And that is one of the reasons why we were indicating that the evidence was there to support a vaccine mandate at the time.
Thank you, Ms. Thompson. No, you're past time, Mr. Bachrach, but you will get another turn. Ms. Goodrich, please, for 5 minutes.
Chair. Thank you, Mr. Chair, and thank you to all the witnesses. So, Ms. Thompson, a little bit along the same vein, so you were, earlier on in your testimony, you were talking about how under Alpha and Delta, the transmission of the virus, there was studies to show that it was less so with those that were vaccinated. But then you said that things changed with Omicron. As we know, Omicron became the variant that was probably dominant in around December, January. So was the interest in keeping the federal vaccine mandates for travel in place from January onwards mostly in trying to get more people to get vaccinated?
Thank you, Mr. Chair, for the question. Of course, we were facing a very strong resurgence. The science was still emerging with respect to Omicron. It takes, although it happens very quickly in pandemic time, it still takes a while for the pandemic science to emerge with respect to effectiveness of vaccines against certain variants, and just to understand how a particular variant is presenting. So certainly, in terms of the surge of Omicron, there was certainly evidence to support that we were in a surge, and it was happening not only in Canada but globally as well, and that it was we should be maintaining efforts to encourage individuals to be as protected as possible from a vaccination perspective, as well as personal protection measures. All right.
Thanks, Ms. Thompson. Unfortunately, we don't have much time. So my question becomes, it's relatively clear. At a certain point, it became pretty clear to Canadians and to science around the world that vaccines did not change whether people could get or transmit the Omicron variant. We have our Prime Minister who's now been infected with the Omicron variant for the second time in about 6 months. So did us keeping vaccine mandates in place in Canada for federal travel, was that in order to encourage more people to get vaccinated? A simple yes or no would be great.
It was, as I indicated, to ensure that Canadians had the protection during this latest wave of COVID. And We know that the effectiveness has been demonstrated through studies to still be present even during the Omicron wave. Yes, it does wane over time, probably faster than with Delta, but it still prevents transmission. Maybe I'll see if Mr. Bent wants to add anything.
Thank you. I would add that, as was stated earlier, 2 doses of vaccine still does offer considerable protection in terms of severe disease. And fundamentally, in the context of our objective of reducing hospitalizations, severe illness, and death, 2 doses performs well. We do know, though, as well, that 3 doses performs better, and that's why we're encouraging Canadians to get their booster. Thank you.
No, and thank you. And so then perhaps in follow-up, was keeping federal mandates and restrictions a way of encouraging more Canadians to get vaccinated? Yes or no?
I would offer that we've consistently communicated to Canadians that vaccination is one of the most important measures to protect themselves and to protect others.
Well, so one of the complicated pieces around all of these vaccine mandates has been that there's been so much politicization, and a lot of Canadians have lost trust. They don't understand what is different today compared to yesterday in terms of being able to get on a plane. Like, what magically changed that now today is safe, whereas yesterday was unsafe? So you've got a whole amount of fear. There hasn't been a lot of communication with the general public that perhaps thought that those mandates were in place for some specific reason. We don't have any answers in terms of metrics as to why these mandates have been kept in place for as long as they have. We don't follow any of our G7 partners while travel, and so much is a global phenomenon. Canada kind of stayed on its own, keeping a very different, we were out of step with our US partners, we were out of step with our European partners, we were out of step with just about everyone in the world. And now Canadians that believe that Canada was doing this are now confused as to how somehow it's now safe. So what would you tell those Canadians as to why there was a change, an overnight change in these mandates and restrictions?
Thank you, Mr. Chair. I would assure Canadians that this is based on the data and the engagement with experts. As I said earlier, we're constantly engaging with experts on the world stage, nationally as well, engaging with provinces and territories.
Ms. Thompson, what data and which experts?
Thank you, Ms. Goodrich. Ms. Shanahan, please, for 5 minutes.
I would like to thank the witnesses for being here today. It's my first appearance at the Health Committee, and so I'd like to ask questions that I know are top of mind for residents in my riding. First of all, monkeypox. Over the past couple of weeks, we've seen an increase in cases. I know it's very concerning in Montreal as well. In Quebec, we've seen some cases on the rise. Can you tell us what the agency is doing to actively work with public health partners to investigate reports of suspect cases of monkeypox in Canada?
Thank you, Mr. Chair, for the question. I will ask Dr. Poliquin to respond to that.
Thank you, Mr. Chair. I would like to reassure Canadians that the Public Health Agency of Canada is taking the monkeypox situation extremely seriously. We have had a number of concrete actions with respect to monkeypox. First, following the international reports from the UK on May 17th, the National Microbiology Laboratory relaxed instantly its criteria for testing to remove the need for travel, to make sure that all Canadians were able to access the testing that they needed. In addition, there was an emergency meeting of the Canadian Public Health Lab Network on May 19th, prior to the confirmation of the first 2 Canadian cases, to ensure that there was readiness on the laboratory side. In addition, we have been working hand in glove with our provincial and territorial partners to provide guidance. Within 8 days of the first cases being detected in Canada, we issued guidance on the prevention of infection as well as recommendations to prevent spread. Through the National Emergency Stockpile, we have made available vaccination, third-generation vaccines intended for smallpox, but with also an indication for monkeypox for a targeted vaccination campaign to help reach those that were most at risk. In addition, ongoing communication has been occurring both through provincial health authorities, but also a number of community organizations in order to ensure that messaging is out, but respectful, that we do not enter into an area of engendering unnecessary stigma. The Public Health Agency stands firmly against stigma generation, and as such, our communication strategy has been very mindful to both reassure Canadians and also get the message out to those who need to hear it.
My constituents are also worried about long COVID. And I understand that there have been some studies recently about the syndrome's origins, the risk factors, the treatments. Can you tell us, I guess Ms. Thompson or anyone on the team there, what steps the Public Agency of Canada, the Public Health Agency of Canada, is taking to learn more about post-COVID, this post-COVID condition, and what the factor of being fully vaccinated, how does that impact subsequent long COVID?
Thank you, Mr. Chairman. Maybe I'll take those in that order. We are at the agency working to monitor and build an evidence base to inform public health decision-making with respect to post-COVID or long COVID. We are working with a number of partners closely to make sure that we build that evidence base, starting with Statistics Canada. We are going to be launching a population-based survey on post-COVID conditions to look and identify some evidence gaps and try to estimate what the percentage of the Canadian population is that is currently experiencing post-COVID conditions. And then we would propose to do a follow-up survey, a second survey with Stats Canada. We're also working with the Canadian Institute for Health Research and also with the Canadian Pediatric Society to look at some options of studies looking at the impact on children. So I think we'll be in a position later this fall to be able to detail the full scope of the work that's underway. We're also monitoring a number of systemic reviews that are happening worldwide as well. In terms of the evidence and how it relates to vaccination, the evidence review by the agency found that the prevalence of post-COVID-19 condition is approximately 30 to 40% in individuals who are not hospitalized for their initial COVID infection. And the current evidence suggests that the prevalence is even higher for those who were hospitalized during acute phase compared to those who weren't. So there is a strong indication that that vaccination helps to prevent in long-term or post-COVID conditions.
Thank you, Ms. Thompson. Ms. Shanahan, Monsieur Garand pour 2 minutes et demie.
2.5 minutes, Mr. Gall. Thank you, Mr. Chair. I have a question again for Ms. Thompson on long COVID, because we were just talking about it. I'd like to understand something in Quebec right now. If you know the epidemiology of long COVID, how many people at this point seem to be showing symptoms that are longer than 6 months and that are incapacitating? Do we have an answer to that? Hello, Mr. Chair. Yes, I think that's part of the challenge, is that we don't have accurate, exact data, rather, but I'll check with Dr. Poliquin as to whether there may be further information. I know it's difficult to estimate the number. Yes, we're in a situation where we are continuing to refine the definition of long COVID or post-COVID symptoms. What are the criteria to define it? At this point, we don't have a specific estimates, but through the work of the Public Health Agency and with our partners, we are refining the definition thereof, and we're also setting up studies and polls to better determine prevalence. Okay, thank you. You're saying that we have some information, but the clinical definition is not yet up to date or finalized. That's what I've been hearing, or that's what the witnesses said last week before the committee. But I'm still wondering, on your side, are you concerned as to the effect it could have over the long time on the labor force, on with specifically in the healthcare system, because we know there may be a risk for people who were exposed before their vaccine doses. That some of our healthcare workers, many were exposed before the vaccines were rolled out. Is that a concern you have? Dr. Poulican, did you want to answer that one? Of course, we take long COVID syndrome very seriously, and this is why we are investing and working with partners to do these studies. It is too early to know at this point what the long-term effects will be. We know, for instance, just one study has shown, just a few days ago it was published, showing that the risks of long COVID following an Omicron infection are far less than they would be compared to, say, Delta. I think we're in a situation where there are a number of different processes at work, and we are working to see and investigate what the real ramifications of the problem are so we can respond to that. Thank you, Dr. Poulican. Mr. Garon.
The last round of questions will come from Mr. Bachrach for 2.5 minutes, please.
Thank you, Mr. Chair. Now to Ms. Thompson, continuing with questions regarding the vaccination mandate for domestic travel, there are two government decisions that are of particular interest. The first was the decision on June 1st to extend the travel mandate, and the second was the decision 2 weeks later on June 14th to lift the travel mandate. Were both of those government decisions consistent with advice from your department?
Thank you, Mr. Chair. Of course, I can't speak specifically to advice provided to the government, to ministers as part of the cabinet process, but I can say, as I've stated before, that that the science and the assessment of the Public Health Agency supported the decision to lift the vaccine mandate. We, as I said earlier, appreciate that it's also required on the part of the government to be able to appreciate and consider the information that they receive from different sources, and so
did the evidence that your department collects also support the decision on June 1st to extend the mandate? You spoke to the lifting of the mandate. Did the evidence you were collecting and the science you were reviewing also support extending the mandate on June 1st?
Mr. Chair, as I said, we are constantly reviewing the studies and the evidence and the information that's provided to the government is consistent with what we were seeing at the time when the mandates were being lifted,
that we talked about the lifting already. We're talking about the extension of the mandates now. I'm just frustrated because I'm asking different questions, but you're giving the same answer to every question. And what I want to know is whether the information you were looking at PHAC was supportive of extending the travel mandates on June 1st.
Okay, Ms. Thompson, that was the last question. You won't be interrupted. Take as much time as you need to answer it.
Thank you, Mr. Chair. Mr. Chair, I don't mean to repeat the information, but I can only share with you that the evidence fully supported the decision to implement the mandates with respect to the timing. As I say, the evidence is constantly evolving. New studies are coming out. Dr. Pelican was talking a moment ago about a study a few days ago on long COVID. So the information is it's very fluid in this pandemic that we are all living, and we're constantly considering and reconsidering the data. And what I can say is at the time when the government lifted the mandate, that the public health evidence supported lifting of the mandate.
Thank you, Ms. Thompson and Mr. Bachrach. To all of our witnesses from the Public Health Agency of Canada, we appreciate you being with us, your patience and your professionalism. I don't know that the work of the Public Health Agency of Canada has ever been more visible than in recent times, and we certainly appreciate you being here with us and so patiently and professionally handling the questions that were posed to you today. So I wish you all a good evening. Colleagues, I have a very pleasant task for you before we wrap. Today is the last meeting for our analyst, Sonia Norris. Sonia will be retiring in exactly 9 days. So Sonia, just a little bit about Sonia. She earned a master's in biochemistry and spent almost a decade in clinical research. Started with the Library of Parliament 24 years ago in 1998 and was assigned to this committee. Her first study on this committee was on natural health products, and some of the other studies that she has penned include organ donation and transplantation, assisted human reproduction. From 2012 to 2019, she worked in the other place. On the Social Affairs, Science and Technology Committee, wrote a number of reports, including a series on pharmaceuticals, as well as healthy eating, dementia, and robotics. In all, she's drafted about 26 committee reports. And I can tell you that as the chair, I get to meet weekly with the analysts from the Library of Parliament and the clerk to plan the business of the meetings. And Sonia has always been professional and pleasant and good-humored to deal with. And I'm sure that you join me in wishing her a happy and productive retirement. Hear, hear. Now, to Sonia's left is Kelly Farah, and Kelly is going to be attempting to fill the large shoes left by Sonia. She certainly has the credentials, Masters of Science in Epidemiology, as well as a Master's of Library and Information Science, 15 years of experience working in the field of health technology assessment. Prior to joining the Library of Parliament, she was a pharmaceutical review manager with Canada's Drug and Health Technology Agency. She's also, yes, as I read it, she sounds very much like a witness as opposed to somebody that will be on our side. She's worked with PHAC as a research analyst and with the NACI, the NACI Secretariat. Areas of expertise include clinical and economic evaluation of drugs, vaccines, and medical devices, and methods for knowledge synthesis in the health sciences. So please join me in welcoming Kelly to our committee as the analyst.
Only 24 years to go.
Is it the will of the committee to adjourn the meeting?
Yes.
We're adjourned. Thank you.